Wonderful. For our next presentation this afternoon, we have Francois Marvel. Francois is the co-founder and CEO of Corrie Health, in addition to the co-director of the Johns Hopkins Digital Health Lab and a cardiologist at Johns Hopkins. It's my pleasure to turn it over to you, Francois.
Thank you, Heather, so much. I'm delighted to be here. Thank you as well to Pat Dunn for the invitation and Cassie and Darcy, who did a lot of behind the scenes to get us all together. Incredible to be on such an innovative, inspiring panel. I want to take the time to really dive into what's important here in innovation, and that's really our patients. Corrie's mission is to provide innovative digital health solutions that, like a lot of our team members here on the panel have mentioned, we're trying to deliver guideline-directed care and really do this in a way that's equitable, that reaches all of our patients, not just a few. And we know there's a lot of challenges to that. So our health delivery system remains much unchanged, even though we have challenges of poor outcomes, expensive procedures, long hospital stations and stays, and the patient experience is honestly a lot left to be desired. Let's take heart attack, for example. So we oftentimes, using Johns Hopkins as an example, do an excellent job of door to balloon time. And we're really able to get that heart vessel that's been blocked causing the MI revascularized or bypassed. But what really comes as a challenge is the patient's experience and connection with what's next. So a lot of times patients are on bed rest, seeing the clinical team for just a few minutes every day. And really when it comes to hospital discharge and heading home, they're left with a stack of patient instructions that oftentimes leave them confused, leave them wondering what medications they should be on and who they should be following up with. And this can be very dangerous and concerning, especially with cardiovascular disease. In fact, heart attack readmissions are a major problem. They're costly, and importantly, there's something we can do something about. So 1/6 of our heart attack patients come back to the hospital within 30 days, and that number only gets higher at 60 and 90 days. And 75% of these readmissions could be prevented, which leaves a lot of opportunity for us to really improve our healthcare delivery. It's a costly problem, not only for managing the costs associated with that readmission and the morbidity associated with that, but also Medicare and our healthcare systems are getting penalties for something that could be prevented, and really to try to incentivize healthcare innovation. Corrie really focuses on how can we change and re-engineer the way that patients are recovering after a cardiovascular event, are trying to improve their life and follow those guideline-directed therapies. And so instead of just having everything at the end of the hospitalization, Corrie meets the patient right as they're admitted for a heart attack, for example. Patient develops chest pain, comes to the hospital, and while they're there, and I'm using a patient who's actually published with us, she's done case studies, she's an incredible individual, inspires many of us. This patient, she's an example of many patients that we've treated with Corrie. She was given Corrie on a smartphone, which she actually only had a flip phone, didn't really have access. She's underserved, multiple risk factors, smoker, hypertension, hyperlipidemia. This is her second heart attack. She had undiagnosed familial hypercholesterolemia. And she's sitting in that hospital bed without a clue of what to do and without any help or support. We were able to get Corrie in her hands, which is an application that really walks her through guideline-directed medical therapy, keeping on track with her meds. It's connected with a smart watch that helps send reminders. It also tracks heart rate and steps and encourages just-in-time interventions to help promote patients to do the right thing right in that moment. And it also connected with a blood pressure cuff, so she could help get better control of her blood pressure. She used that while she was hospitalized for about 3 to 5 days. And then she used it while she was heading home for that really vulnerable 30, 60, 90-day period where patients are really at risk for having challenges with connecting with their healthcare. And so what we found in expanding what we did in creating Corrie into a multi-site clinical trial is that just as Tammy experienced, this patient with multiple cardiac issues that didn't know how to connect with cardiovascular care, but was able to get Corrie at the right time, engage in guideline-directed therapy, and stay consistent with it. she was able to avoid hospital readmission and complications of another MI. And that's exactly what we looked at in the MyCore trial. So what we did is we evaluated 200 patients at Johns Hopkins Hospital, a community hospital, Johns Hopkins Bayview, Massachusetts General Hospital, and Reading Health. And we gave them Corrie at the time of diagnosis of an MI while they're in the hospital. They used Corrie during the hospitalization. And at that 30-day post discharge process, we looked at the healthcare data, we looked at EMR, we looked at administrative data, we looked at insurance claims, and we determined whether these patients were re-hospitalized at that time point. What we found in comparison to patients who had an MI a year before in a historical control group that were essentially matched to equal our Corrie group so that there were no confounding variables, we found a 52% reduction in 30-day all-cause readmission. Again, and these are propensity groups. So a group of AMI patients that were about 864 in a historical control versus 200 patients that had MI that used Corrie. And that was a pretty incredible outcome that we discovered here. What we attribute it to is likely that Corrie drives engagement. It gives the tools to the patients at the right time and when they're having an opportunity to really be motivated to change. 90%, over 90% of our patients had high levels of patient activation, which was measured in a validated patient activation measure scale called the PAM score. We also found that it was possible to get these tools in the hands of patients, even in high acuity settings like the intensive care unit, coronary care units, and step-down units. We also published, along with publishing our main findings in Circulation Cardiovascular Outcomes, we also just recently published in Medical Care that there's a major benefit to the system to reduce the costs associated with those readmissions. And when we did a Markov analysis using economic modeling of 10,000 cases of AMI patients using Corrie, not using Corrie in routine care, there was a $10,000 savings per patient in using the Corrie platform in order to have better recovery after a cardiac event like an MI. And what's more important than health equity? Really, it is a core theme as physicians in the American Heart Association and just generally as people. We want to reach everyone. And I want to emphasize that the experience that we had with Corrie and Tammy is she's not someone you might often see having a smartphone or that might use technology. Her health digital literacy was low. Her ability to have these resources was not possible based on her low socioeconomic status. And it really changed her life and saved her life, as she mentioned in our publication together in our case study. So I think, again, this is a way to extend our reach and really reach people who need it the most. So I'd like to walk you through and close this presentation with what this platform looks like and what are some of the key components that really make a difference in our patient population here after a cardiovascular event. So we first get patients started, whether they're iOS or Android, with signing up for Corrie and getting some key information about them. So first, just enabling notifications so that they can get connected to the calendar and the core features of their phone. Then what we do is we have them personalize it so that this is part of their experience. This is their partner going through this recovery. We ask about questions like smoking that are key for getting them resources. And then we also ask about social determinants of health, which are so key in cardiovascular health and health in general. Then we want to really educate them and make them feel comfortable with using wearables and technology. So we do tutorials on how to use a blood pressure cuff and how to do it properly so that we know this is valid data that's coming through for us. We do the same for Apple Watch and Fitbit. So we want to make sure that using this technology is easy for them and they can check their medications on their watch and use the features to the fullest advantage for their health. We also show them how to track their heart rate and what that means in terms of being on medications that adjust their heart rate or affect their heart rate. We also want to encourage physical activity like workouts, and they can do that from their watch as well as in the Corrie application. We have a commitment to extending the technology across our population in all of our communities. In fact, we developed a novel loaner program that we used during the MyCore study that provided the technology to patients. So we actually had 92 of our 200 patients using loaner technology just for those 30 days so that they could benefit from that during a most vulnerable period after a heart attack. We also have upgraded from those paper-based instructions they received to these incredible high-quality videos that really dive into what the problem is that they're experiencing, like a heart attack, and make it visual, make it easy, and make it able to connect and empower our patients. We make sure that we also have a language profile, including Spanish, so we can reach even more patients that might be left behind with other approaches. It's also really critical that our patients have the opportunity to get back to everyday life. For example, we provide structured exercise programs through Corrie. So they're able to participate using a safe to participate checklist. They can click on getting started. And then once they get started, they actually get to join an American Heart Association trainer that walks with them on this 30-minute indoor walk or outdoor walk and helps them to connect with heart healthy tips, all building this new life of heart healthy living. Of course, we provide the basic foundation of diet, nutrition, weight loss, making sure that they understand at a very easy level what they need to do to improve their health. We also provide actionable tools like 1-800-QUIT-NOW, which they just click on and they're able to get free nicotine replacement therapy resources delivered to their home. Lipid management, blood pressure management, diabetes management, these are all key topics that we cover through the Corrie application and through the platform to help encourage a heart healthy life. We also encourage them, we congratulate them, we give them kudos. When they finish their educational goals, we reinforce that to keep them motivated and engaged in the program throughout the duration. And then our clinicians, our coaches, they're able to plug into the dashboard of the health data that's flowing from those tools that I just reviewed. We're able to look over a week, 2 weeks, and 30 days about how their heart rate, blood pressure, step counts are doing. We use heat maps to be able to look directly at what their medication adherence is like and give them feedback about their education completion and really target their educational training goals. We also make sure all this data is backed up in a very high security level of Kubernetes Google Cloud Platform, which we've migrated from AWS or Amazon Web Service to make this scalable, fault tolerant, and reliable. So our patients are confident that their data is under the strictest and tightest of security. We know clinical workflow. Myself, Dr. Martin, one of our other co-founders here, we're frontline cardiologists, and we know exactly how this needs to roll into hospitals and work with the current clinical workflow since we take care of these patients as well. Thanks for your attention. I'm really excited to share Corrie with you and be part of this program. Thank you.
Wonderful. Thank you so much, Francois. We do have some questions for you.
Great.
The first question is actually, I think, a recurring theme or a building of theme of what we've heard for some of the other presenters today, but it has to do with workflow. So I think we've heard the comment that most physicians are not looking for additions to their workflow. So the audience would love to hear from you. How did you get this into the workflow and make it so that the actual system and the administrators were okay with this?
Yes. Yeah. So perhaps one of the best questions here and the most relevant, because if we're going to make these tools work, we need them to be able to actually get into practice. So our experience from MyCore and our current projects are that there is a human factor here in terms of whether it's a nurse that's involved in this care or a mid-level provider that interfaces with the patient, that's able to connect them with the technology. So our workflow was essentially, we used an Epic trigger to identify that the patient had an MI. That was automated. It would go essentially to a MyChart in basket, and we were able to look and screen for that patient having an MI. Once we knew they were eligible from the program, then we would send what we call a Corrie navigator, someone to the bedside to talk to the patient, and they would have a Corrie tote. The tote would have in it blood pressure cuff and the smartwatch. They would meet the patient, interact with them, introduce them to the program, and then get their email and be able, right there at the bedside, to be able to get Corrie downloaded. Now, if the patient was available for about 20 to 25 minutes, they were able to get them uploaded not only to Corrie in the program, but also to 2 wearables. And so you can imagine if you were to do this as an app-only approach, you could really think of a clinical workflow that's as much of a conversation or a Zoom with the patient getting an email and then translating that over, getting the download and having that conversation. But from our experience, there's something really important about the kickoff with the patient, and that opportunity to really engage, empower, make sure you answer all the technical questions, and then they launch.
Wonderful. And our next question is, I think, really interesting because we are still in this pandemic. There's still some emergency use that is helping us from the perspective of how to provide things digitally. So could you talk to us a little bit about that post-discharge, how long you're able to stay with this patient, how you're able to get paid for this, and do you have concerns as we maybe hopefully end a pandemic and go into this endemic that people are talking about? Will that change at all?
Yeah, that's so all of those questions incredibly important, especially given the workflow is different right now. I wouldn't expect that. So let me tackle the first question. The first question is, in the setting of the pandemic, where we were given discretionary access to patients across the country without having a license within that state, I do not believe that will continue. Although I think it's a very interesting and it would be really meaningful for digital health, I don't think that you could have your one team in one state and expect to be able to reach all 50 states through these emergency access policies. I do think that a lot of opportunities exist where you have champions within states and within hospitals, where if you're doing remote monitoring, you can connect with these different champions and these different leaders, and then have a presence within each state very easily. So I think that we can work and innovate around that space. In terms of being able to get paid for a system, yes, absolutely. Right now, what we're working on specifically, part of what I showed you in this model is working on virtual cardiac rehab model. So taking our first version of MyCore and now expanding it to a larger model that also involves not just AMI patients, but valve patients, heart transplant, heart failure, and really expanding the model. When we look at getting paid within that model, there are codes currently that exist for cardiac rehab being done digitally. And in the current policy, there's a lot of policy advocacy. There's a lot of push towards continuing those codes, but it's not a guarantee. The other way that you can get paid for this type of digital health work is that you are using the CPT codes for chronic monitoring and RPM. So you're basically, and if people want to reach out to me with more specifics about that, I'm happy to walk through it. There's codes you can be applying on a monthly basis based on a certain amount of time that you spend with the patient and what you're reviewing, and if you change the care plan. There's also review of data, including images, EKG, or other data that comes through, like the dashboard review, in small conversations that can also be billed. And then there's some additional CPT billing based on additional time that you spend. So there's a model of cardiac rehab that's currently being billed. There's a model of CPT codes that you could be applying to that. And then, of course, there's other opportunities within hospitals to just agree on an opportunity for a shared cost savings model, where you're essentially saving the hospital money from reducing readmissions, improving experience, improving HCAHPS scores, and you're sharing in that savings together, which is a more innovative and challenging approach. But those are some, just a quick response there.
Thank you so much, Francois. I think what I'm taking away from that last response is stay tuned. This is like an exciting novel that has yet to be finished yet. So we'll be following you closely on that.
Perfectly said, Heather. Thank you so much.
All right. Make sure you monitor that chat for some other feedback and comments as well.